a lecture on neural tissue pain disorders. Okay? Pain from neural tissue. Okay, so the neural tissue pain disorders, we're interested in particular when the patient comes with back-related leg pain. Because when the patient comes with back-related leg pain, we want to know, is this related to the nerve itself? Is the nerve inflamed? Are there any signs of compression of the neural tissue that causes leg pain? Or maybe it's a somatic referred pain, so it refers maybe from a disc or facet, but we cannot find anything neurally wrong with the patient. So maybe reflex are intact, muscle power is okay, sensation is okay as well. Now, nerve damage does not always cause pain, and probably we did come across in your clinical practice as well. Maybe patient comes in for shoulder pain, but they're dragging the leg, you know, like a foot drop. But they may come with some completely different issue to your clinic, maybe shoulder pain or neck pain, and they tell you that they say, look, you know, I never had pain. I just one day, I could not lift my, or do dorsiflexion. So you can go through a process of degeneration or some nerve tissue damage without any source of symptoms. Okay? But it's true also, for example, for tendinopathies as well, as we know. People never complain of any tendon pain. They went, played basketball, hopped, landed, and completely torn the tendon. So you can go through a process of degeneration, including the tendon, and you can have complete tear of a tendon. Like, and that's quite common in middle-aged men, you know, with, let's say, Achilles tendon rupture. Because the healthy tissue never ruptures, because the, you know, the tendon cells, tenocytes, are very, very strong. Like you've got type 1 collagen, so usually it's very strong. So only the unhealthy tendon or degenerative tendon can tear, not healthy tendon. It can be painful, but not always. So most common painful neuropathies such as diabetic neuropathy and post-herpetic neuralgia, pain present in only 20% of patients. So some people may have some signs of nerve damage but no pain. Traumatic nerve injury causes pain in less than 10% of patients, and stenosis occurs in 21% of asymptomatic people over the age of 60 years, and severe stenosis in 30% over 40 years of age. And I think sometimes why stenosis is not always painful, because stenosis doesn't happen overnight, isn't it? So it occurs over the years and years, isn't it? Changes in the spinal canal. And maybe the spinal cord has time to adjust for changes in an intervertebral foramina or in a spinal canal. Okay. Also, we know that people with carpal tunnel syndrome, you can have also a percentage of patients who are asymptomatic. Okay. So the reason why we're discussing this, because if we decide to do like nerve mobilization or nerve sliders and gliders, we don't need to do for all patients with nerve pain or nerve-related issue, I should say. And you can see that here, this study was in Japan, and severity of stenosis, you know, so we had 938 patients, but again, some of them were asymptomatic. Even with the severe stenosis, some people have no pain. Okay. But of course, when we see patients coming to the clinic, they're usually in pain, so we want to work it out. What is the reason? Why they have pain, and what is the problem? Now, we know that a lot of evidence to suggest now that pregabalin, such as Lyrica, is not really great for treating neuropathic pain. And it's almost, and Alice had mentioned about Lyrica as well, that almost no difference between control group or placebo group. Yeah. So Lyrica doesn't seem to have a good effect on medication. Now, lots of studies in terms of nerve recovery post-trauma is being done on the rats, because obviously we wouldn't get ethical approval to do that on the humans, so a lot of studies been done on the rats. So this study, what they did, they crushed this rat's nerve, okay? And what they did after that, they had 15 sessions of 9 minutes passive ankle dorsiflexion, mobilization, 1 day post-injury. And what they found over time that hyperalgesia, mechanical hyperalgesia, motor function, histology, morphology, and immunochemical function improved in rats after the injury. Okay? And inhibition of glial cell activation. The glial cells, remember we talked about, is all around the body. In fact, it's around 70 to 80% of glial cells are in the body. So the nervous system is composed of 80% of the glial cells. So if you're not sure about glial cells, you can read up on that a little bit, yeah? So what it tells you that movement promotes nerve recovery. Movement mobilization promotes recovery of the nerve. Another study, again, so they constricted the sciatic nerve on the rats, and the rats were given either daily progressive exercise on a treadmill for 50 to 60 minutes or swimming. And they weren't that nice to the rats. You know, what they did, they put the rats in the pool. When the rats started to drown, they took them out of the pool, gave them a bit of rest, and put them back in the pool. Not that nice. Even the rats, I feel sorry for them. But again, what they found all the time, that mechanical and thermal hyperalgesia reduced. Pro-inflammatory cytokine levels also reduced, like tumor necrosis factor, interleukin 1 as well. So don't worry about those. But basically, what it sort of suggests that exercises has endogenous opioid release. So it also reduces the inflammation. Okay. Okay. Again, this study looked at rat sciatic nerve injury, and they did again daily progressive exercise for 30 minutes, 7 days post-surgery for 14 days, but then attenuated pain by 3 weeks. Okay. So what happened? So they got them to exercise, and after that, for a period, they stopped exercising them. And what they found when they stopped exercising the rats, their pain returned. So what we know, we need to continuously doing some mobilization or exercises to promote recovery. So they exercise, effect on exercise reversed with opioid receptor antagonist. So, because when you exercise, it regulates endogenous opioids. And especially in that acute setting, so the body releases natural opioids in the system. But of course, it does not probably happen as often when you have chronic pain. When you have persistent pain, the natural endogenous system is impaired. And that's why what we need some medication for some patients, isn't it? To try to help them to reduce the pain that shuts down the messages going from the spinal cord into the brain and vice versa. Good. So mechanism of exercise in reducing neuropathic pain, again, sometimes it's a bit unclear, but certainly what we know, it reduces those pro-inflammatory cytokine production. Tumor necrosis factor, interleukins, B and 6. And increases anti-inflammatory cytokine production, because cytokines can be pro-inflammatory or anti-inflammatory. So really promotes that anti-inflammatory effect. Good, and similar study, again they did exercise the rats post chronic constriction of the sciatic nerve. And again they got them to Wheelwright for 6 weeks, prior to and after chronic constriction of injury. And again, they found that allodynia improved. Also, neuroimmune signaling in the dorsal horn also was dampened, reduction of that. Okay. Suppressed pro-inflammatory cytokines and increased anti-inflammatory mediators. Okay. Again, movement prevents pain, promotes recovery, and releases pain. Now, the question is then, is movement effective in humans? So we know a lot of studies being done on the rats, but is movement effective in humans? Is movement important for all nerve disorders, or only chronic, or maybe acute? Is specific nerve movement necessary? Now, this is what is the evidence for low back-related leg pain in humans. So what we know that more than 50% of disc reabsorbs spontaneously and occurs in 88% of cases post-symptom onset. So remember I said to you guys, so that you can have disc resorption. So, and what they found in some of the studies that the bigger the disc prolapse, the more chance for the disc to reabsorb as well. Okay? But disc reabsorption, it doesn't mean that you're going to have pain reduction. So there's always that correlation between pathonatomical changes and symptoms does not always correlate. We also know that some people can have complete pain reduction or improving pain, return to normal function. If they did MRI scan, they would found the same disc prolapse or even the signs of nerve compression, but no pain. So I think the message is here that we treat the person, but not the X-ray. But it's a valid point. I think people do ask, so is this disc going to improve? We can, based on our status, look what we know. Some disc reabsorbs. So we give them kind of a good information what we know from the research. But also we say we know also that even despite you may still see visible disc prolapse, but your symptoms may improve. So we give that if they ask that question. And look, favorable prognosis is in most cases, but 30% still have pain 1 year later. And to be honest, if you think about shoulder pain, similar. You know, despite the treatment that we do, percentage of patients, they still have this chronic, persistent shoulder pain even 1 year later. So with all musculoskeletal conditions. But I think the only thing what we need to understand, what are the good prognostic factors in recovery, and maybe what are the factors not so good in prognosis. So that's why we're profiling patient, asking questions, and then think about, okay, what is likely for this patient to improve? What we know, people who have widespread pain, allodynia, hyperalgesia, could be cold or heat hyperalgesia. Now also the patient's got high on psychosocial issues, such as depression, anxiety, fear, longer period of symptoms. These are not so great prognostically, especially if you've got depression, clinical depression. We're not talking about depression where I feel down because I have pain. I felt down, to be honest, in the first couple of days. I couldn't do things that I normally do. I can't still go to the gym, so it's really annoying me. So I don't feel fresh. So, so I'm getting down, but I'm not clinically depressed. So if you have a clinical depression, and that also can identify that Aribo questionnaire. Remember those 10 questions we talked about? So I do ask a patient, so is this you down because of your pain you down, or in fact you've been diagnosed with depression? So if they've got a clinical diagnosis of depression, what we want to know, are they managing depression well? So maybe they're not managing it well. Maybe the medication is not working. Maybe it's not reaching the therapeutic effect. So again, we might need to talk to the GP. Then the GP can sort of look at that and alter the medication. But it could be that they're just down because they're in pain. So just be mindful of that. And this is what factors predict recovery in people with low back leg pain. Shorter pain duration, leg pain severity if it's on a lower scale, less other symptoms like sleep disturbances, fatigue, unable to sit, patient beliefs. So also what we know, if people are more optimistic, that's a better chance of recovery. If people are a bit more negative, then again it's a bit of going towards that, maybe a bit of complication in terms of recovery. And also mitochondrial weakness. So these are the factors that you may think, okay, which patients are likely to improve, which may have some barriers in recovery. Okay, good. So, this study was done on 60 patients with arm and neck pain, consistent with nerve inflammation. So PNS is peripheral nerve sensitization. So these patients were randomized to neural mobilization, less neural exercise and advice. So they had 40 patients in that group. Or they had a control group, like 20 patients. So just told them to stay active. Nothing specific, just stay active. And they had 4 treatment sessions over 2 weeks, and they followed them up at 4 weeks. The outcome measures they used is global rating of change, so how patient satisfied, neck disability index, pain, and patient-specific functional scale. So remember about patient-specific functional scale? So we asked the patient, what things are you struggling with? And they rate 0 to 10. They're sitting or walking or running, can they? And what they found in conclusion, that dual mobilization provided immediate clinical relevant benefit beyond staying advice or staying active. So we've got some evidence to suggest that neurogliding and sliding when the nerve is inflamed can have a good effect, not only statistically but clinically as well. Now, in contrary, so this study was published in Australian Journal of Physiotherapy, and if you look at the title, it says neurodynamic treatment did not improve pain and disability at 2 weeks in patients with chronic nerve-related leg pain. So when you read this this article or the title of it, sorry guys. So when you read this title of the patient, then it almost sounds a bit depressing. So things that we do with neurosliders and gliders that may not work, huh? But what happened? The researcher had to report the symptoms of how they improved at 4 weeks, and at 4 weeks the experimental group experienced at 2 weeks. Sorry, 2 weeks, and at 2 weeks they did not improve. But at 4 weeks, the experimental group had a good effect in terms of reduction in leg pain and lower back pain. So we know that the chronic or like even acute or subacute conditions don't recover just in 2 weeks. They recover, and you will see from the rest, typically 8 to 12 weeks. So looking at a sort of 3-month mark. So we're not expecting the patient to improve like that immediately. Okay. Good. Alright. Now, how we classify neural tissue pain disorders? Initially we used to classify syndrome-based, like diabetic neuropathy, post-herpetic neuralgia, MS, radiculopathy. But syndrome-based classification did not explain pain, nor does help us to decide what treatment to do for these patients. So if you look at this X-ray, so this X-ray being done in April 2019, yeah? So you can see quite that big central disc prolapse compressing the spinal canal. So this patient has symptoms, yeah? And then you look in July, this same patient, same prolapse, no symptoms. So it tells us we can improve patient's symptoms despite changing the X-ray. You know what I mean? So we treat a person, but not MRI scan, not X-ray, because pain is multifactorial and it's a bit complex. It's not just, pathology and pain. As we see more and more studies to show that the symptoms with pathanatomical changes correlation is very minimal in a lot of cases. Now, if we're looking at mechanisms of neuropathic pain, so we have both peripheral and central pathophysiological mechanism. So we have changes in the dorsal root ganglion, okay, but also we have changes in the dorsal horn. Now, we know that A delta and C fibers, they are sensory nociceptors. They inform the spinal cord or the dorsal horn about changes in mechanical, chemical, and thermal pressure. Okay? So if there is some changes, if you've got some inflammations, then the chemical nociceptors are going to be activated. Okay? But also, in neuropathic pain scenario, even the non-pain sensory fibers can get activated, like A-beta, because A-beta is more proprioception, genital pressure. They don't really inform the dorsal horn about pain. But in that situation, when you have peripheral mechanisms involved, these then become activated as well. So you're almost like adding spices to the soup. So it becomes more and more things activated. Now, if we look at that, at the synaptic cleft, or cleft if you like, also in the dorsal horn, you have ion channels. So the ion channels open up. Then they also release a lot of pro-inflammatory chemicals, okay, like cytokines, and so on. So really have a lot of different changes basically in that dorsal horn, but also in the central nervous system. So you get that increased sensitivity, okay? And the typical signs of that neuropathic pain, you get what? You get sharp shooting pain, because you have some damage, so you may have ectopic firing. That means the pain comes for no apparent reason. So you can sit there and the pain just shoots like electrical shock. Okay? They may have also strange sensations such as dysesthesia. So basically dysesthesia is strange sensations like water running down the leg and scrolling down the skin. They may describe you that. Okay? But also symptoms such as hyperalgesia, could be to mechanical stimulus, thermal stimulus as well. Okay? There is another classification system that's been developed by International Association of Pain classification system for neuropathic pain, and they got this grading system. And the grading system is really tells us, okay, how confident can we be that this patient's got neuropathic pain? Okay? And what they say, if these patients are positive on all four of these categories, it's definitely neuropathic pain. If it's only 1 and 2 plus 3 or 4, is probable. And it's only 1 and 2 only, it's possible, so it's less confident. So it's really how confident can we be this patient's got neuropathic pain. So the criteria is if the pain is with a distinct neurotomically plausible distribution, like in the dermatome or myotome, for example. History that suggests relevant lesion or disease affecting peripheral somatosensory system. So maybe the patient say to you, they have a trauma to the nerve, for example, in the history. Number 3, demonstration of altered nerve function by at least one of confirmatory tests. So maybe you do your nerve conduction test, so patients being sent for a nerve conduction test, or in your clinical nerve function test, neurological exam. So maybe reduction of power, maybe reduction or enhanced sensation, so it can be positive or negative symptoms, both. Okay. But other things that's a problem with clinical or the nerve conduction test, the nerve conduction test only tests the motor function of the nerve, not sensory. So you may have false negative because they don't test the sensory fibers, they test the motor fibers. So it doesn't really often exclude as well. So there are some issues as well with nerve conduction tests as well. And number 4 is demonstration of relevant lesion or disease by at least one of confirmatory tests, like investigation, okay, such as maybe MRI scan or some other supplementary examination. So really it's about how confident can we be to say this patient's got neuropathic pain versus maybe only one test is positive, the rest is negative. Yeah, so it's like with SHA, so the more tests are positive, the more confident we can be that this patient's got neuropathic pain. Okay, so I think guys it's 25 almost to 1. We're going to stop here for lunch for an hour and then we'll continue on the lecture. So make sure you don't eat too much because I think we might be falling asleep. Alright, have a nice lunch and we'll see you after.